My name is Paula Chatterjee. I'm an assistant professor of medicine at the Perelman School of Medicine. I'm also the director of health equity research at the Leonard Davis Institute of Health Economics. And today we're talking about the Medicaid Disproportionate Share Hospital Payment Program, which I'm going to refer to from here on out as the DSH Payment Program, was really started with the express purpose of providing additional financial support to hospitals and other healthcare providers that disproportionately serve low-income patients. The program really was born out of the fact that Congress recognized that there are providers that serve this group of patients, and as a result, they incur financial difficulty in doing so because these patients have a harder time paying for their care than other patients might. And so the goal of the program was really to codify recognition of this mission-based service that these providers were offering to patients. So the DSH program has been extremely important to the financial viability of safety net hospitals in the U.S. for decades. There are some hospitals that make the case that without DSH payments being made available to them, that they would go into precipitous financial decline to the point where their doors might have to close. And so if you ask safety net hospitals, the DSH payment program is really one of the main sources of financial support that they rely on to provide this care to low-income, uninsured, and underinsured patients in the U.S. The total federal funds that go into this, and it's a combination of state and federal funding, is somewhere between $20 and $25 billion. Our estimates are a little bit lagged based on data availability, so it makes that estimate a little bit fuzzier than we might like, but that's the general ballpark of what we're talking about here. So back in the 1990s, researchers found that a sizable proportion of Medicaid DSH payments were not necessarily reaching the hospitals and the providers that they were designed to reach in the first place. They were getting caught up in something called an intergovernmental transfer, meaning that the funding was being pulled down from the federal government to states, but then states had quite a bit of freedom in deciding where they could actually allocate that funding at the end of the day. Some of it went to hospitals, some of it went elsewhere. And so we've known that that's been true in this program really for several decades now. And in response, Congress really tried to tighten up the extent to which that intergovernmental transfer was taking place. What our paper finds is that we focus specifically on hospitals and the types of hospitals that are getting DSH payments. And what we find is that while a large proportion of DSH payments are getting to hospitals that serve safety net functions, meaning that they serve patients who are insured by the Medicaid program, or they're hospitals that provide a lot of uncompensated care, we do find that maybe up to 30% of Medicaid DSH payments might not be reaching those types of targeted hospitals that they were supposed to reach in the first place. We know that that money is associated with better inpatient outcomes, meaning that when DSH money gets to the hospital that it's supposed to get to, things like inpatient mortality from heart attack gets better for those patients. Things like neonatal mortality improve when payments get to where they need to go. So it's not like we're just talking about, money in the healthcare system in sort of a more abstract sense. What we do know is that when this money is targeted effectively, patients benefit in really meaningful ways that are salient to their hospital care. And so the fact that there is potentially a large degree of mistargeting in the DSH payment program means that we're not just leaving money on the table, but we're leaving potentially patient improving and quality improving money on the table. This is money that could go to tremendous good use for a group of patients that is disproportionately at risk for bad outcomes in the first place. We have some prior work showing that the way that we currently allocate Medicaid DSH payments might be subject to some structural racial biases. What do I mean by that? Well, we did an analysis looking at where Medicaid DSH payments go to hospitals and where the population level burden of disease exists for Black patients and white patients. And so we focused on counties where there were particularly large populations of Black people relative to counties where there were relatively small populations of Black people, and those were actually predominantly white populations. And what we found is that Counties with disproportionately large Black populations have much higher population health needs, but commensurate to that, they do not receive the amount of Medicaid dish payments that you would expect them to receive. In fact, they receive quite a bit fewer Medicaid dish payments for what their given population health needs would otherwise suggest that they need. And so what that's telling us is that the money is going to hospitals, it is supporting certain hospitals, but whether it's actually reaching hospitals that serve communities with high levels of population health need, which we know are often disproportionately Black and brown counties, is not quite clear. And it suggests that there's a real opportunity for us to change the way that we think about targeting these payments so that they reach the counties that could benefit from them most.